Hello, I'm Christophe Lambert, and I'd like to share with you a network study I did with this large set of collaborators across the OHDSI network, predictors of diagnostic transition from major depressive disorder to bipolar disorder. Why do we care? In our data, we've seen as many as 40% of bipolar patients are first diagnosed with major depressive disorder. You would treat people with major depressive disorder differently than bipolar. For instance, an antidepressant would potentially trigger a manic episode in somebody with bipolar disorder. And a recent meta-analysis showed that it's hard to find factors that consistently predict the conversion from major depression to bipolar. So we sought to use machine learning to develop a model that would hold up over a large set of databases within the OHDSI network. The approach we took was to first select patients who did not have major mental illness prior, no evidence that they've either been taking the meds or had any of bipolar, schizophrenia, schizoaffective disorder, or major depressive disorder. They had to be over 10 years old, at least a year of observation, and a year after the major depressive disorder. We trained models on market scan, commercial claims and encounters, Medicare, Medicaid, and Optum databases. We used the Cyclops regularized logistic regression for testing for predicting whether someone converts from a depression diagnosis to bipolar diagnosis within the coming year. We use the entire set of covariates from Hades, patient-level prediction package, and then we developed a parsimonious risk score-based model using subject matter expertise. We looked at Kaplan Meier analysis in the decade after conversion, stratified by a risk score, and we validated across a large number of external databases. The approach we used to develop a simpler model was we binned our ages in 5-year intervals using 60 to 69 as a reference age, so we could cover databases that both spanned above and below the age of retirement of 65. And a subject matter expert developed composite covariates iteratively within our training set. We took correlated covariates with similar medical problems and merged them together into a single covariate if they had the same direction, magnitude of effect across our 5 different training sets. We also expanded those composite covariates to incorporate related codes from SNOMED and drug ingredient vocabulary hierarchies. And covariates with small coefficients or inconsistent direction were excluded from the model. And so then we took our final set of coefficients, we averaged across the different models, multiplied by 10 round to the nearest integer so we could get an easily computable integer risk score. And interestingly, we observed no appreciable change in the area under the curve as we simplified our models. So here's the results in our 5 different training models, the AUCs ranging from 0.63 to 0.74. You see these were some rather large databases with a fair number of outcomes and quite a range of outcome percentages in the year following major depression. This is the conversion to bipolar. We saw in our external validation across a large number of databases, is Columbia, Japanese claims, various IQVIA European data sets, Stanford, the US Veterans Administration, and the Korean EHR, a comparable set of AUCs, some going a little below 60 with Columbia, and some going as high as 78%. Of course, these are rather small sample sizes, but in general, from a 60 to 70% area under the curve. We see stable area under the curve by year when you look at the databases have a decent sized number of samples per year, a little bit of a swing in this IQVIA German data set, although again, it was a bit of a small sample size. But generally, we see a slight rise or a neutral predictions over time across our databases. Here is the model. More severe major depression was a big factor in whether you converted, either having severe versus mild, being protective, if you will, and psychosis being a big risk factor for conversion. prior other not major mental disorders, anxiety, higher risk. If you had postpartum depression, you have a lower risk of conversion to bipolar, as well as substance misuse and thoughts or actions of self-harm enhanced your risk. Younger people had a higher risk than older people, and you can basically check the boxes that fit you, pick the appropriate age score, sum them up, and get a predicted risk, which can be below 1% up to as high as 50%, and you see these risks varying over the different databases. When you take the risk score of 0 as a reference, and you look at from -8 up to the 40 maximum, you see as much as 20-fold higher risk at the highest end within the CCAE data. And this is the Kaplan Meier curve stratified by risk. Here's every risk score combined in the pink line, and you can see the higher risk scores have a much higher conversion rate, and the lower risk scores have a lower conversion rate. And there's a steep initial conversion, but then that risk continues to persist all the way looking out a decade into the future. So in conclusion, we were able to use a data-driven approach across multiple data sets to identify 9 key predictors of conversion from MDD to bipolar. The simple model out of sample in our validation sets got an area under the receiver operator curve ranging from about 0.6 to 0.7 across a broad range of databases. We see the risk of MDD to BD conversion continues to persist a decade later, and we can stratify by our risk scores. And this risk methodology can be used to identify either retrospectively patients who maybe we should go back and check that have a higher risk, or at the point of diagnosis, one could identify patients with higher risk using the simple score we developed. So you can look in more detail of our models on the data.odyssey.org website, and I look forward to your exploration of our work. Thank you.